Today we're diving into hypertension management in Canada. It affects, what, about 1 in 4 adults?
That's right, a huge number. And worryingly, recent data shows we've seen a bit of a slide in treatment and control rates.
Yeah, that is concerning. Which brings us to the new guidelines from Hypertension Canada. They've put out a 2-part update.
Correct. And we're focusing today on the part aimed squarely at primary care. It's designed to be really pragmatic, for everyday practice.
Using the WHO Hearts framework, too, I believe, to streamline things.
Exactly. It integrates the recommendations into some clear algorithms. Makes it quite practical.
Great. So our goal here is to pull out those key takeaways on diagnosis and treatment, specifically for you listening pharmacy students and practicing pharmacists.
Let's jump in. Diagnosis first.
Okay. Recommendation 1 seems to be all about how we measure blood pressure.
Absolutely fundamental. Accurate BP measurement using a validated automated device. And using a standardized method. That's the cornerstone.
Why the emphasis on automated devices? Most of us learn manual auscultatory methods.
Well, the automated oscillometric ones are generally easier to use consistently. They reduce human error and give more reproducible results day to day, patient to patient.
Makes sense. And validation is key here, right? Not all machines are created equal.
Not at all. Globally, maybe only 10% of devices have solid validation evidence. But the good news is, here in Canada, something like 90% sold in pharmacies are validated.
That's much better than online sales, I gather?
Yeah, significantly better. Online, it's closer to maybe 45%. So advising patients where to buy is important.
Are there times manual is still the way to go?
Yes, definitely. Things like persistent arrhythmias or in specific groups where the automated devices haven't been validated. Think certain pediatric populations, maybe.
Okay. And the standardized method, what does that involve exactly?
It's about preparation and consistency. The patient needs to rest quietly for, say, 1 to 5 minutes first. No caffeine, smoking, or exercise for 30 minutes before.
Right, the usual prep.
Yeah.
And positioning.
Crucial. Sitting, back supported, feet flat, legs uncrossed, arm bare, supported at heart level. And very importantly, using the right cuff size.
And then take multiple readings.
Yes. 3 readings about a minute apart. Then you average those.
And if you don't follow this carefully...
Well, your readings could easily be 5 to 10 millimeters of mercury higher than they should be, which, could lead to misdiagnosis or overtreatment.
Okay, so accurate office BP is step 1. What's the second diagnostic recommendation?
It's strongly recommending out-of-office BP assessment. That means either ambulatory BP monitoring, ABPM, or home BP monitoring, HBPM.
Why the push for out-of-office?
Because those readings, especially ABPM, correlate much better with actual cardiovascular events and mortality risk compared to just office readings.
Right, and it helps catch things like white coat hypertension.
Exactly, or masked hypertension, the opposite problem. White coat is pretty common, maybe 15 to 30% of people with high office readings. Masked is less common, maybe 10 to 15%, but tricky.
Can you briefly describe ABPM and HBPM?
Sure. ABPM uses a device worn for 24 hours, taking readings automatically every 20-30 minutes, day and night. Yeah. HBPM is the patient taking duplicate readings, usually morning and evening, for a full week at home.
What if those aren't available? Can you just rely on repeated office measurements?
The guideline says you can, using that same standardized technique we discussed, but it acknowledges this approach has lower specificity. It's not as good as ABPM for confirming the diagnosis.
Got it. So out of office is preferred, if possible. Now, the third diagnostic point, the actual definition of hypertension, has that changed?
Yes, it has. This is a key update. Hypertension is now defined as a BP of 130 over 80 millimeter Hg or greater.
30 to 80, that's lower than previous guidelines.
It is. The change is based on, a lot of observational data and clinical trials showing that cardiovascular risk really starts to increase at these lower levels, and that treating to lower targets has benefits.
So people with BPs in that 130, 139 systolic range have a higher risk than those below 120?
Significantly higher, yeah. Maybe 1.5 to 2 times the relative risk for major cardiovascular events.
This lower threshold means more people will be diagnosed, right?
It does. But the guideline committee felt the evidence supports earlier identification and intervention for better long-term outcomes. It's about reducing that cardiovascular risk proactively.
Okay. That covers the key diagnostic updates. Let's switch gears to treatment. What's the first recommendation there?
No surprise here, really. Healthy lifestyle changes, advised for all adults diagnosed with hypertension.
The foundation.
Absolutely. Unhealthy habits are huge contributors. So tackling things like diet, especially salt intake.
Right. The WHO recommends less than 2 grams of sodium daily. That's tough given processed foods.
It is. Over 70% of our sodium comes from processed stuff, not the salt shaker. So label reading and food choices are key.
And potassium.
Increasing potassium is also good, mainly from fruits and vegetables. WHO suggests over 3.5 grams daily. Just need a bit of caution in patients with CKD or on certain meds that raise potassium.
What about weight?
For patients who are overweight or obese, weight loss definitely helps lower BP. Even newer weight loss meds like GLP-1 agonists show promise here too.
And exercise. Always important.
Vital. Dynamic aerobic exercise shows clear BP benefits. The goal is typically 150 to 300 minutes of moderate activity per week.
Alcohol.
There's a dose-response thing. Reducing intake if someone drinks heavily, say more than 2 drinks a day, can significantly lower systolic BP. Less impact if intake is already low.
And smoking. Does quitting directly lower BP much?
The direct effect on BP itself might be modest, but smoking's overall cardiovascular risk is massive. So cessation counseling is essential for everyone with hypertension, period.
Okay, lifestyle first. When does pharmacotherapy come in? That's recommendation 2.
Right. Meds are recommended if BP is 140/90 or higher.
And also for some people with lower pressures.
Yes. Also, if the systolic BP is between 130 and 139 and the person is at high cardiovascular disease risk.
Okay, let's unpack high risk. How is that defined?
The guideline lists specific criteria, adapted from ESC guidelines and the SPRINT trial. It includes things like having established cardiovascular disease already, diabetes, moderate to severe CKD.
What about risk scores or age?
Yes, a 10-year Framingham risk score of 20% or more, or being age 75 or older, also puts someone in that high-risk category for this purpose.
So for those high-risk folks with BP 130, 139, meds are recommended. Why? Stroke risk reduction.
Primarily, yes. That's where the evidence points for that group. But always remember, meds complement lifestyle changes. They don't replace them.
And maybe down the line, meds could be reduced or stopped if lifestyle changes work really well.
Potentially, yes. That's always a possibility to revisit.
What about people with BP 130, 139 who are not high risk?
For them, the initial approach is lifestyle changes alone. Then reassess their BP in about 3 to 6 months.
And if it's still up but risk is still low?
Continue lifestyle efforts and reassess maybe every 6 to 12 months. Meds aren't automatically started in that scenario.
Got it. Now, the third recommendation, the treatment target. Where are we aiming?
The general target is a systolic BP of less than 130 millimeter Hg for all adults with hypertension, as long as the treatment is well tolerated.
Less than 130, again, reflecting that evidence for more intensive control.
Exactly. RCTs show fewer cardiovascular events and lower all-cause mortality reaching that target compared to, say, aiming for less than 140.
Some trials aimed even lower, like less than 120 in SPRINT. Why not adopt that target?
Good question. The guideline committee considered that, but opted for less than 130 as the general recommendation. They cited differences between research BP measurement and clinical practice, trial specifics, how often the 100 target was actually met, and also feedback from providers and patients about feasibility and potential side effects.
So 130 is seen as a more pragmatic target for broad application.
That seems to be the reasoning, yes. Kind of balancing the strong evidence for benefit with real-world practicalities.
Is there a specific diastolic target?
Not really, no. If the systolic is below 130, the diastolic usually follows. The focus is on the systolic target.
What about the risks of intensive control, hypotension, falls?
They acknowledge those potential harms, hypotension, syncope, falls, electrolyte issues, maybe acute kidney injury, but the data generally suggests the absolute risk of these is quite low.
Are there exceptions to the 130 target?
Oh, definitely. It has to be individualized. Factors like patient goals of care, significant frailty, high fall risk, or problematic orthostatic hypotension might mean a higher target is more appropriate for that specific person. Patient-centered care is key.
Okay, that makes sense. Moving to recommendation 4, how to start pharmacotherapy.
This is another significant shift. The recommendation is to initiate treatment with low-dose combination therapy, ideally as a single pill combination, or SPC.
So starting with 2 drugs at low doses right away, often in 1 pill.
That's the preference, yes. Using drugs from 2 of 3 main classes, ACE inhibitors or ARBs, thiazide or thiazide-like diuretics, and long-acting dihydropyridine calcium channel blockers.
Why those 3 classes?
They have complementary mechanisms, they're generally well tolerated, and robust evidence shows they protect against cardiovascular events.
What about beta blockers?
Not recommended first line anymore, unless there's a specific reason, like post-MI, heart failure, or angina.
Important safety note with ACEs and ARBs.
Critical one. They are teratogenic. So avoid or stop in pregnancy or if planning pregnancy. Counseling women of childbearing potential is essential.
And diuretics, any preference between thiazide like chlorthalidone and thiazides like HCTZ?
The evidence is evolving. Previously, thiazide-likes were often favored, but recent data suggests similar efficacy. Chlorthalidone might carry a slightly higher risk of hypokalemia, though.
Why start with combinations? Isn't monotherapy simpler?
Simpler, perhaps, but most patients, especially aiming for 130, will need more than one drug anyway. Starting with low-dose combos gives additive BP lowering while minimizing side effects you might get from high-dose monotherapy.
And the single pill combination aspect, why is that preferred?
Several reasons. Evidence shows SPCs can lower BP more effectively than taking the same meds as separate pills. They lead to better BP control rates compared to starting with one drug.
Adherence must be better too.
Definitely. Adherence is better, maybe persistence too. Plus, it helps overcome therapeutic inertia that delay in adding or increasing meds when needed.
Any impact on outcomes or cost?
Possibly fewer cardiovascular events and deaths, though more research is ongoing. And often SPCs can be cost-saving for the patient compared to two separate prescriptions.
Are there downsides? More side effects overall?
Interestingly, withdrawal rates due to side effects seem similar between SPCs and free combinations, though some studies note slightly more dizziness with SPCs compared to monotherapy, perhaps just due to better BP lowering.
Okay, so initial therapy is ideally a low-dose SPC from two of those three classes. What if BP is still not at target? That's recommendation 5.
Right. If BP stays high on 2 drugs, the next step is a 3-drug combination.
Which 3?
The logical step is one from each of those preferred classes, an ACEI or ARB, a thiazide or thiazide-like diuretic AND, a long-acting dihydropyridine CCB.
That specific trio is recommended.
Yes, based on their proven benefits. And a strong warning. Never combine an ACE inhibitor with an ARB. No added benefit, just increased risk of adverse events like hyperkalemia and kidney injury.
Are there single-pill, triple combinations available?
They exist elsewhere and are very effective, but unfortunately not yet available here in Canada. So it means taking 3 separate pills for now, usually.
Okay. What if even that 3-drug combo at max tolerated doses doesn't get the BP to target?
This is resistant hypertension, right? Recommendation 6.
Exactly. That's resistant hypertension. In this situation, the guideline suggests adding spironolactone.
Why spironolactone specifically?
This comes largely from the Pathway 2 trial. It showed spironolactone was more effective at lowering BP in resistant hypertension compared to adding placebo, or other options like doxycycline or bisoprolol.
Is there a reason it works well in this group?
It's thought that dysregulated aldosterone production might be quite common in resistant hypertension, so blocking its effect with spironolactone makes sense physiologically. Does it improve outcomes, like reducing heart attacks or strokes compared to other fourth-line options?
We don't have direct prospective data on that, specifically for spironolactone versus other agents in this setting. The recommendation is mainly based on its superior BP lowering effect, shown in Pathway 2.
What about side effects? Hyperkalemia is a known risk, right?
Yes, hyperkalemia is the main concern, especially in patients with CKD or those on other drugs that raise potassium, like ACE-ARBs. So careful potassium monitoring is absolutely essential.
Any other notable side effects?
Gynecomastia, or breast enlargement tenderness in males, can occur due to its anti-androgen effects. Patients should be counseled about that possibility.
And for resistant hypertension, should we also be thinking about secondary causes?
Definitely. The guideline advises considering screening for secondary causes and referral to a specialist. Particularly screening for primary aldosteronism before starting spironolactone is often recommended.
Makes sense. The guideline also includes algorithms you mentioned.
Yes. Figures 2 and 3 provide clear visual pathways for diagnosis and treatment based on that WH-Hearts framework. Very helpful for quick reference in practice.
And they suggest a specific initial combo.
They highlight irbesartan hydrochlorothiazide as a preferred initial SPC, but Table 3 lists other acceptable alternatives, factoring in cost-effectiveness too.
So overall, these lower thresholds and targets will mean more diagnoses, but it's evidence-based for long-term benefit.
That's the key message, yes. Earlier intervention, more intensive control where appropriate and tolerated, aiming to reduce the significant burden of cardiovascular disease linked to hypertension.
Great summary. So wrapping up, the new Hypertension Canada Primary Care Guideline really emphasizes accurate, standardized BP measurement, often confirmed out of office.
Right, and adopts that lower 30/80 diagnostic threshold, aiming for a systolic target below 130 for most patients.
Lifestyle changes remain absolutely foundational.
Always. And the pharmacotherapy approach is stepwise, favoring starting with low-dose combinations, ideally SBCs, using those 3 core drug classes.
Then adding sequentially, considering spironolactone for resistant cases, while always watching for side effects and individualizing care.
Precisely.
So the final thought for you, our listeners, pharmacists and pharmacy students. How can you take these pragmatic, updated guidelines and really integrate them into your practice? Think about how you counsel patients on BP measurement, lifestyle, medication adherence with SPCs, and monitoring, all to help improve hypertension care and reduce cardiovascular risk across Canada.
Definitely explore the full guideline and resources on the Hypertension Canada website. There's a lot more detail there.
Excellent advice. Thanks for walking us through these important updates.
My pleasure.